Welcome to the Dr. Izzy's Medical Podcast channel.
Essential thrombocythemia. ET. Essential thrombocythemia is a rare chronic blood cancer characterized by the overproduction of platelets by megakaryocytes in the bone marrow. It may, albeit rarely, develop into acute myeloid leukemia or myelofibrosis. It is one of 4 myeloproliferative neoplasms that occur when the body makes too many white or red blood cells, or platelets. Signs and symptoms. Most people with essential thrombocythemia are without symptoms at the time of diagnosis, which is usually made after noting an elevated platelet level on a routine complete blood count. The most common symptoms are bleeding, blood clots, for example, deep vein thrombosis or pulmonary embolism. Fatigue, headache, nausea, vomiting, abdominal pain, visual disturbances, dizziness, fainting, and numbness in the extremities. The most common signs are increased white blood cell count, reduced red blood cell count, and an enlarged spleen. Cause of essential thrombocythemia. In ET, megakaryocytes are more sensitive to growth factors. Platelets derived from the abnormal megakaryocytes are activated, which, along with the elevated platelet count, contributes to the likelihood of forming blood clots. The increased possibility of bleeding when the platelet count is over 1 million is due to von Willebrand factor sequestration by the increased mass of platelets, leaving insufficient VWF for platelet adhesion. A mutation in the JAK2 kinase is present in 40 to 50% of cases and is diagnostic if present. JAK2 is a member of the Janus kinase family. In 2013, 2 groups detected calreticulin mutations in a majority of JAK2 negative/MPL negative patients with essential thrombocythemia and primary myelofibrosis, which makes CALR mutations the second most common in myeloproliferative neoplasms. All mutations affected the last exon, generating a reading frame shift of the resulting protein, that creates a novel terminal peptide and causes a loss of endoplasmic reticulum KDEL retention signal. Diagnosis. The following revised diagnostic criteria for essential thrombocythemia were proposed in 2005. The criteria are as follows. Platelet count greater than 400 times 10 to the power of 3 microliter for at least 2 months. Acquired V617F JAK2 mutation present. No cause for a reactive thrombocytosis. Normal inflammatory indices. No evidence of iron deficiency. Stainable iron in the bone marrow or normal red cell mean corpuscular volume. No evidence of polycythemia vera. Hematocrit less than midpoint of normal range or normal red cell mass in presence of normal iron stores. No evidence of chronic myeloid leukemia. But the Philadelphia chromosome may be present in up to 10% of cases. Patients with the Philadelphia chromosome have a potential for the development of acute leukemia, especially acute lymphocytic leukemia. No evidence of myelofibrosis. No collagen fibrosis and less than or equal to grade 2 reticulin fibrosis. No evidence of a myelodysplastic syndrome. No significant dysplasia. No cytogenetic abnormalities suggestive of myelodysplasia. Treatment. Indications. Not all those affected will require treatment at presentation. People are usually split up into low and high risk for bleeding, blood clotting groups, based on their age, their medical history, their blood counts and their lifestyles. Low risk individuals are usually treated with aspirin, whereas those at high risk are given hydroxycarbamide and/or other treatments that reduce platelet count, such as interferon alpha and anagrelide. Agents. Hydroxycarbamide, interferon alpha and anagrelide can lower the platelet count. Low-dose aspirin is used to reduce the risk of blood clot formation unless the platelet count is very high, where there is a risk of bleeding from the disease, and hence this measure would be counterproductive as aspirin use increases the risk of bleeding. The PT1 study compared hydroxyurea plus aspirin to anagrelide plus aspirin as initial therapy for ET. Hydroxyurea-treated patients had a lower incidence of arterial thrombosis, lower incidence of severe bleeding and lower incidence of transformation to myelofibrosis, but the risk of venous thrombosis was higher with hydroxycarbamide than with anagrelide. It is unknown whether the results are applicable to all ET patients. In people with symptomatic ET and extremely high platelet counts, plateletpheresis can be used to remove platelets from the blood to reduce the risk of thrombosis. Prognosis. Essential thrombocythemia is sometimes described as a slowly progressive disorder with long asymptomatic periods punctuated by thrombotic or hemorrhagic events. However, well-documented medical regimens can reduce and control the number of platelets, which reduces the risk of these thrombotic or hemorrhagic events. The lifespan of a well-controlled ET person is well within the expected range for a person of similar age but without ET. ET is the myeloproliferative neoplasm least likely to progress to acute myeloid leukemia.